When we learned about Nanox, we were amazed by the technology and saw immediate relevance to our client base. It fits all boxes. Great technology, simple to deploy, affordable, improves healthcare. So without further ado, I want to introduce to you Dr. Larry Tanenbaum. I've known Dr. Tanenbaum for over 25 years. Um, he's a well-respected radiologist, executive medical director of Nanox. Throughout his career, he's helped bridge clinical practice, academic medicine, and emerging imaging technologies to improve diagnostic performance and patient care. Previously, Dr. Tanenbaum served as Associate Professor of Radiology and Director of Advanced Imaging Development at the Icahn School of Medicine at Mount Sinai. He is a frequent speaker, published author on medical imaging, artificial intelligence, and healthcare innovation, and has delivered more than 1,500 presentations worldwide. So without further ado, I'll introduce Dr. Lawrence Tanenbaum and his experience with Nanox and its technology.
Well, welcome everyone. I'm pretty excited to have this opportunity to talk about 3D tomosynthesis in clinical practice. Let's see that slide. So I have a choice of reading this to you or telling you a little story. And the little story I want to tell you while you read it, which I assume we're all doing, is that I became aware of this technology before I signed up to be an executive medical director for Nanox, and I found it sufficiently compelling that I was anxious to jump on board. You may be familiar with tomosynthesis. It's been around for a long time. I remember I used to do tomosynthesis for IVPs in the old days, and we'd sometimes see, renal lesions we couldn't see otherwise. The fundamental principle, of tomosynthesis lets you see things with less overlap. But these days, most people know of tomosynthesis because of mammography. The systems that did tomosynthesis in day-to-day practice were large, they were expensive, and they required a lot of power. And it had limited really clinical application quite a bit outside of the mammography area. What we're excited to talk about today is the Nanox.ARC, which is a much smaller unit, more elegant unit that fits almost anywhere, and it fits into workflows in a number of different clinical settings. It uses a novel X-ray tube platform, which is very low dose and generates very little heat, essentially a digital X-ray tube, which makes it practical in so many different circumstances and enhances access over what it would take to put a traditional tomosynthesis machine in place. If you look at the comparison between, say, CT systems would do what CTs do, and X-ray systems and do what X-ray systems do, as you know, on an X-ray system, you've got to look through all the anatomy and you basically look at shadows, and CT has the ability to discretely give you individual slices so that you can see things that you never could see before. Tomosynthesis fits in between the two, where you can actually slide through the anatomy and get individual components of the body in sharp focus. But more importantly, for this particular slide, I want you to look at the power supply. You notice it's only 1.8 kilowatts for the Nanox.ARC, 70 kilowatts for a typical X-ray system, and up to 100 kilowatts for a CT system. You'll notice that the weight is lower than an X-ray system, a lot lower than a CT, and the size is just about the size of an X-ray machine. So where would it fit? It would fit into an X-ray room. So for the most part, we're just going to talk about clinical applications here today. And frankly, the area where it builds, probably most of the excitement is in musculoskeletal indications. Although, believe me, I think I'm going to surprise some folks by the time we're done, because we will be talking about things outside of MSK, but you'll be able to see the obvious application in imaging the extremities, bony abnormalities of the hips and pelvis, as well as the spine over the next few minutes when we look at some cases. Now, here you see a typical scenario that might show up in practice where the patient's in a cast, really hard to see what's going on about maybe in this case, suspected fracture, if the patient came from a urgent care center and now is being evaluated by an orthopedic surgeon. If you look at the tomosynthesis, we can slide right through to just the right image and then allow us to see the comminuted intra-articular fracture of the distal radius, as well as the fracture of the ulnar styloid that, would be almost impossible to see in those circumstances. Here you see a patient with, again, who's in a splint of a sort, suspected fracture of the foot. I can't see much of anything on the full volume x-ray exam, but when we look at these tomosynthetic slices, you can clearly appreciate the fracture of the fourth metatarsal base, and just beautifully seen, even though the cast or splint is in place here. Now here's an elderly patient with a fall. We know there's a left hip fracture there somewhere. It's really hard to see. You can already see the situation with the right hip, probably already been fractured. It looks like a little bit of protrusion on the right, but when you look at the left hip, it's really hard to say there's a fracture there, even though we all kind of know it has to be there. Taking a different x-ray view, it's still hard to be definitive. Maybe a little more suspicion on this projection, but hard to be definitive. Now, notice that as you slide through on the right-hand side, eventually the tomosynthetic slices will go right through the plane where you can see the fracture definitively, the offset of the humeral head-neck junction, as well as the neck fracture, not too terribly displaced, but this is what tomosynthetic images look like. Essentially comes out in a series, depending on where you are in the anatomy going front to back, you will see a different part of the exam in focus, and eventually you can see exactly what you need to see here, clearly going beyond the x-ray. And I think one of the themes I'm going to hopefully impress on you today is that patients in your office, okay, you can give an incomplete answer, get something else, get a CT scan, come back in a week, or you can go that one step further with tomosynthesis and be definitive. Get it right the first time. Be patient focused and not make the patient come back for an answer. Just another particular advantage, same case I showed you beforehand, you could actually see on the CT coronal image on the left, the problem that CT has with metal, where you get beam hardening and streak, or signal voids and streak. Due to the nature of X-ray tomosynthesis, we don't have any of those problems with metal, so that it doesn't do anything to interfere with our ability to see. And just to show you what the CT looks like, you can clearly see the offset at the fracture of the femoral head. And again, how nicely the tomosynthesis really demonstrates this finding without the need to get a CT scan, which may not be present in your office, which may require a several-week wait, which may not even be available in the near community where the patient is, and might require some transit. All right, so here's another case, and here we're in the spine. Patient presents with acute back pain. You do the x-ray. It's a gorgeous looking exam. Hard to see that there's anything wrong here. You might call it normal. You might ask the patient to come back in a few weeks if they don't feel better. But in this particular case, tomosynthesis was done because the suspicion was high. And you can see there are superior end plate fractures at several levels. Now, again, this is the definitive answer. In this particular case, the CT was done, and you can see the same finding on the CT with depression of the superior end plates. What's the theme here? Not leaving without a definitive answer, taking tomosynthesis in your own hands and getting that definitive answer, accelerating care and reducing morbidity and mortality in that circumstance. Again, X-ray is wonderful. We all know how good CT is. CT isn't always available. In this case, you can go to X-ray Plus, or essentially get you almost all the way to CT and see things that you just wouldn't see on an X-ray, like this odontoid fracture. Again, why do we see it so much better? Because we're not looking through all the overlapping anatomy. We're sliding right through the critical plane and seeing that fracture. So you can imagine this would extrapolate to any number of different circumstances in the spine and an MSK, and certainly takes you that extra mile. Now, I don't think I need to push you much more with many more examples in musculoskeletal, but I'd like to talk to you about something that perhaps you might not have considered coming in today, and that is tomosynthesis should and could have a very important role in lung cancer screening. Now, that may strike some of you as odd because you used to CT scanning in lung cancer screening. Let's visit that over the next few minutes. So lung cancer screening is very powerful. It is as validated as any cancer screening that we have in medicine today. It delivers early diagnosis, early treatment, and a definitive evidence of better outcomes. As a matter of fact, a well-performed lung cancer screening program is widely considered to have roughly an 80% mortality reduction. This is a huge opportunity, right? But it turns out that only about 20% of eligible individuals in the United States actually underwent lung cancer screening. And if you could get to 100%, deaths prevented and life years gained would triple. Okay, so why aren't patients getting lung cancer screening? Well, some of it is awareness, right? And some of it is stigma. People who smoke, kind of don't want to know what they don't know, right? They may actually avoid the topic. Clinicians, because of the fuss involved in getting a CT scan, may choose not to prioritize the issue with certain patients, rather focus on something that they can deal with that day. And there is some concern about harms, but I think that's largely been disproved by the results of the clinical trials. There is also some bottleneck caused by the payers, right? There's a lot of things that are required to get things into place so the ducks are in the row so that you can get that CT scan. And there are strict eligibility criteria. And as you may know, 20% of lung cancer occurs in non-smokers. And perhaps the one that, where the tomosynthesis can make a difference, where the ARC can make a difference, is that access to CT may be limited. But as you've already heard, the ARC can basically fit in any X-ray room and could very well be sitting in your practice. So it turns out that the ARC may be able to give you access, but it's not a CT scan. And the impression we've had to date is that chest X-ray wasn't very valuable. But it turns out that the data from the National Lung Cancer Screening Trial was misinterpreted. And using the appropriate statistical analyses, the true benefit of chest X-ray in this population was up to 40%. And this is because they took advantage of contamination between groups, non-compliance between groups, and stopped the screening during the screening period rather than over that patient's lifetime. So in reality, chest X-ray would make an enormous difference in terms of outcomes, up to 40%. As a matter of fact, the impact of chest X-ray is now seen to be even greater than the impact that CT was perceived to have that led to the reimbursement and the endorsement of the better outcomes in these circumstances. If indeed you started with a screening program with a chest X-ray and went to CT when you needed to, you could get as much as 80% better benefits. So I think the key point here for you to take home for this particular piece is that the value of chest X-ray and lung cancer screening has been seriously underestimated. Okay, so we got chest X-ray, we got CT, we know all of those. So where does tomosynthesis fit in? Well, it turns out that tomosynthesis takes you beyond the X-ray, just like it does in those skeletal examinations, right? You see this particular patient, here's the X-ray. I don't see much of anything. However, when we do tomosynthesis, you can see there's clearly a sizable lung nodule here. So just as in musculoskeletal, there are additional insights that can be gleaned from tomosynthesis that takes you beyond the X-ray, almost as far as the CT scan. And we'll see how it compares to CT over a few minutes. Let's start off with the dose piece, because low dose, CT lung screening was dependent on the use of low doses. And by definition, the dose of a low dose CT is less than 3 millisieverts. In reality, if you're good at using your equipment and you're well connected and wise, you can do even much better than that. But that's still, 1, 2, 3 millisieverts. A chest X-ray has as little as 0.1. A full digital tomosynthesis exam is only 0.2. So nowhere near the range of 3 millisieverts. So the dose is actually very positive. So how does tomosynthesis fit in the CT era? Well, it turns out that it does show you things that chest X-ray can't, like helping you see things that are in the hidden areas behind the heart, near the diaphragm, and showing you, in this case, there's a sizable nodule here that you'd be hard-pressed to see there in this case. So a big difference. Here again, you can see the tomosynthesis. Eventually, we will slide through a lesion hiding behind the heart here. And there's the CT correlate on the left. Now, the CT offers information that the tomosynthesis doesn't. In many cases, it offers something, but again, access in your office. You can easily see how, if there is a question or if you had heightened suspicion because of the patient's demographics, you might be able to go the extra mile before the patient left your office. All right. So what else is tomosynthesis useful for? Well, it has been proven to be useful for problem solving when you think there may be something on the chest X-ray. In this case, in this particular paper, showed that using tomosynthesis avoided the need for CT in 3/4 of cases. 3/4 of cases didn't have to come back for a CT scan, didn't have to go through the dose of the CT or the cost of the CT. Here's an example. Again, nothing much to see on the X-ray. And there you can see the lung nodule at the lung base, fairly sizable lung nodule. Here you see an X-ray on the left-hand side. You can clearly appreciate there's some kind of opacity in the left mid to lower lobe, okay, as well as some disease in the left lung apex. The CT scan shows that it's clearly a cavitary lesion and that there's quite a bit of excitement at the lung apex. Notice how close the tomosynthesis comes to giving you the same information that the CT provides. So again, going that extra step, getting the additional piece of information and not leaving much to be desired. It turns out that in 2016, there was a meta-analysis of the available literature done looking at the ability of tomosynthesis to detect lung nodules of relevance and comparing those to what a CT would be. And you can see in this case, the sensitivity and specificity of tomosynthesis was way beyond what a chest X-ray could do. So really reinforcing that adding tomosynthesis is in the patient's best interest, offering substantial value and more patient-centered care. Here you see an example where very, very hard to see anything, even though I'm showing you where the nodule is on the tomosynthesis exam on the right. Very, very hard to see anything within the lung on the right without the tomosynthesis exam. I think I can run that for you again. I think, yeah, it'll run through again. So there was a large observational study done in Europe. They looked at almost 2,000 patients, and it turns out that looking at the value of digital tomosynthesis, the non-calcified nodule detection rate was comparable with CT in patients at risk for lung cancer. So certainly a viable and useful step to take along the pathway, particularly if CT is not urgently available. Here you see an example, which illustrates the similar point. Not much to see on the chest X-ray, but you'll notice on the tomosynthesis device marked by the red arrow, there is a non-calcified nodule within the left mid-lung. That same observational study showed that when you used digital tomosynthesis and compared it to the CT that followed in the 132 patients that had CT, there was an excellent concordance in the lung RADS classification. So it wasn't just I saw something but then changed my impression when I got to the CT. In many of these cases, almost all of these cases, the lung RADS classification, which means what next steps need to be done, was identical. So summarizing something that really surprised me, I only learned about the undervalue in chest X-ray from going to the last lung cancer screening association meeting and only discovered the incremental value of tomosynthesis over the last couple of years in terms of lung, but clearly we are looking at a tool that takes you beyond the chest X-ray, offers comparable lung cancer detection to CT, dictates the next steps and what needs to be done roughly the same way that CT, and that along with chest X-ray, digital tomosynthesis is a vastly underestimated tool for lung cancer screening and management. So the point of this talk was to offer a little information and education, but this is, Nanox is sponsoring this talk. Ross is the other sponsor. We're really here to focus on this novel platform. So just to bring it all back to the Nanox.ARC, we're talking about a digital X-ray tube which offers a much lower cost, needs less power, generates less heat, fits into the footprint of an X-ray machine, offers value in terms of patient-centered care, being able to image without removing a cast, less problem with metal in braces and internal fixations than a CT does, and really is highly suitable for virtually any setting from the hospital through the outpatient clinic. It offers that next step, that first time right opportunity, so that you have the patient in your hands and you don't leave without that definitive assessment, making the better decision, making the more facilitated decision, getting things right the first time through. So we covered a lot of things today. MSK in spine. Well, look, I typed in abdomen twice because I forgot to put the abdomen in. I guess that's there just to remind me that there are other circumstances where tomosynthesis might be helpful in terms of kidney stones and bladder stones and the like. And I hope that this survey was of interest and that it stimulated at least a few questions and some discussion from the group. Thank you to our sponsors for giving me the opportunity to present this material today, and I look forward to some interaction and some questions. Thank you.